What we're going to do for the rest of the time is look at some videos of children eating. And I want to start by saying a thank you to the parents who allowed us to film them, but to explain how we got these films. I told you about the randomized controlled trial we did with a nurse who went to visit parents at home. As part of her intervention, she took a video of a mealtime. And the reason was, not for research purposes, but was that so that she could sit down with the mother after the meal and go over the meal with the mother and discuss with her how they could have made the child eat better, or how she could have handled things better so the child would eat better. And I think they're a rather extraordinary set of films, and it was when, in fact, a very senior paediatrician in England, Sir David Hall, who was president of the Royal College of Paediatrics, when he saw them, he said he thought this should be compulsory viewing for certainly any paediatrician and any medical student. And I think there are real things to learn from it, if nothing else, just how little we know what goes on in a home when we sit in our clinics and see children. So what we're going to do is I've got the permission of these parents. What we did was we picked out 7 that we thought would be particularly good for training purposes, and we'll see each one in turn. What I'd like you to do is just pass around these sheets. And it would be good if you could actually be disciplined enough to write on the sheet so that you scribble something down and then we can discuss them. And I suppose what I want you to think about while you're watching them is, first of all, what do you see? And the second is, what would you do? So when one's, this looks like a pretty poor slide to see, but the 4 things are important when you look at a meal time. One is the setting. So how is the child sitting? Where are they sitting? If they're sitting at all, who's sitting with them? Are there distractions going on? What's the setup, the framework for the meal? The next is to look at the child and see what's going on there. Is the child allowed to participate in the meal? Are they eating themselves or are they being fed? And is that appropriate for the age? What cues is the child giving? Is the child saying they've had enough and the mother's pushing the food on? Or is the baby actually hungry and clearly could be given more and the mother just doesn't recognize it? How's the child behaving? Are they enjoying the meal? Next is the actual, you may not be able to see it on this, but what food is actually being given? Is it appropriate for age? What are the textures like? Is it appropriate temperature? What do you think of the nutritional content? And then the last one is looking at the carer and seeing where she's sitting. Is that good for the feeding interaction? Is she encouraging the child? Is she making the child eat? What's she feeling about the meal time? So I want you to consider all those as you're filling out the forms. And what I'm going to do is I'm going to show you the growth chart of each child, and I'll tell you a bit of the story. And then we'll show the clip, and then we'll have a discussion, and then I'll tell you what actually happened. Okay, this is Chloe. She's 3 to 4 months old when she was first referred here. Okay, so pretty straight or no weight gain. Chloe's parents have a difficult relationship. Dad has given up work to care for the children as the mum can't cope on her own. They have a violent neighbour and they're in a great deal of debt. Okay, she was admitted here, she was admitted a bit earlier, at 15 weeks for failure to thrive. And she put on weight very nicely in hospital and then was referred to us to follow her up after the admission and see whether we could get the child to gain weight. So this is where I pray that it'll work. And there should be sound with it as well.
Okay.
Okay, that's the brother who's
Bye, Potter. Please. Sit on it. Up here now, do it here. No, sit here. Bring it here. Bring it in then. I don't think so. Big pot here. Big pot here.
Take your potty over there.
Yes. Yes. Quick when push falls. Bring it here.
Okay, do you want to just write down things in each of the columns and then we'll have a discussion? Okay, any comments on what you saw?
There was no eye contact between the mother and the child.
Okay.
Looking away, it was distracted by something else. I don't know, maybe it's the father or something.
I think it was the brother. Okay.
So I think this is the first thing they need to do is some sort of interaction between them.
And how could you encourage that from what you saw in the video? So you've got a mother.
She needs to change all the way of sitting with the baby.
Okay, yeah. So the way the baby was held could clearly be improved.
Maybe if the father is home, like you said, he can take care of the brother and leave the mother full time feed the baby
Yeah.
without having to deal with the brother.
For sure. I mean, the brother's a big part of this distraction.
Give the brother some kind of game or something.
Yeah, give him something to do. Just to,
And he wants going to
yeah.
seeing that the child has difficulty with there's difficulty with feeding here, so you should be more concentrated.
Absolutely. Should be more quality time with that baby. What was the mother feeling, do you think? I mean, what were her emotions? She was impatient.
Because she keeps
Yeah.
an errand of a book. She's moving. She has no patience with the baby at all. She's doing everything else
Okay.
except for feeding him.
But she didn't seem worried.
No, I think I agree with you. She's not worried at all. If anything, she's disinterested.
It seems like it's not bothering her. She's more interested in what the other child is doing. She's communicating.
Yeah. I mean, this is the sort of worry about neglect that I was talking about earlier in England. Here's a baby who was admitted with failure to thrive, gained weight in hospital, and here's a young mother who just hasn't got it together. I think he was 2. Yeah. Yeah. Actually, while it was being filmed, the nurse was worried that the mother was going to drop the baby. I mean, she almost sort of dropped the camera in order to catch the baby. There just seemed to be a lack of focus on what was going on. So what was offered? So there was, I think what you've mentioned this, first of all, I didn't mention, the baby actually finished the bottle during the filming and the mother didn't offer any more. Okay, the baby was hungry still and the mother didn't follow on with more milk. And this was a baby who'd been in hospital because of weight gain. So there was clear things, support that needed to be given and guidance. So the guidance was to feed the baby more frequently. 3 to 4 months, start solids, but this was some years ago. I don't think we'd quite say that now. Positioning was important, distracting the brother with something else to do. We did involve social services here. We got a social worker in for guidance, and the baby was also partly in nursery. There was worry enough about the mother's ability to mother that the baby was on some of the week. So what was the outcome? A lot of support was given. The weight and height went above the second centile. She grew well. I think you could see that from the growth chart I showed you. And her development was normal. Now, you were asking what would have happened if we hadn't stepped in. I don't know. But there were enough concerns about this family that weight gain or not weight gain, it was important to have involvement. Any comments about Chloe? Should we go on to the next? Next is Linda. Okay, she's 17 months old. And here you see her weight gain has been trundling along. And this is the point where she was referred in. And this is the sort of sawtooth pattern I'm talking about, sort of going up and down, rather. I'm worried. Where would you be particularly concerned about this growth chart? What age? Can you see from there? Okay. And sorry, that's we use. Perhaps it's too difficult to ask you about worry. This is the second centile. Second, we use the second in England. At least this is before. These are the old growth charts. Now we use the WHO-based growth charts, and this is the 0.4th centile. So this is really quite underweight. And so when a baby was under that, it's significantly. Is it 1 in 1,000?
She was born over there on the 50th?
She was born on the 50th. By the age of 4 weeks, 8 weeks, she was on the second, stayed on the second, then dropped below.
Already in the first month she was on.
And then started.
After 6 months,
I suppose it depends. Yeah, when I asked this, I wonder.
First month when she was already underfed.
Maybe.
She was born on the 50th percentile and then dropped.
And she dropped.
1 month, I think.
It's probably that. I mean, that might be concerning. Well, it depends. I mean, it depends who the family is and what's going on and the heights and weights. But I suppose when I usually ask this, I think, when should this baby be referred to a specialist? And I'm always curious about where people think it should be. And I think the answer is perhaps it's not worth looking too much at the growth charts, because so much is of what else is going on with the family that helps you decide. But anyway, the point was that she was referred at this point and then came back up there. This is 17 months. Yeah. Okay. Now then, let me tell you about her before you see it. Linda lives with her parents on a large council estate. That's a project in American, I don't know what you'd call it here, Shchuna Chalasha. And they moved there because they were harassed in their previous, the previous apartment block they were living in. Hitzikulem, yeah. The family are lonely and isolated. Linda was always difficult to feed, and at the age of 17 months, her mother always feeds her. Okay. She's not offered any food between meals, and you'll see the house now in the video. Whoops. Seventeen.
Little monkey. Yeah.
Okay. What do you think? What's going on here? Hmm? Excellent. Mother excellent.
First of all, she's sitting like it's not enough.
It's a car seat.
She's sitting down with her. It's a car seat. She's forcing her.
She's
actually younger.
Hmm?
She looks younger.
Yeah, no, she was 17 months.
She looks like she's 28.
Because the way she's sitting.
The way she's communicating to the mother, I don't know.
Okay, maybe you're worried. As I recall, the development was fine. So where would you take this? Okay, so how can one stop her I mean, she's clearly anxious. She wants to get the child to eat. What can help?
They're fighting. They're clearly fighting.
They are clearly
The girl
fighting.
wants to go out of there, and the mother's forcing her. So the first thing is not to fight, to put her somewhere that's easier for the baby to stay. She doesn't like sitting there.
Okay,
To
so
begin with, leave alone, let alone eating. She doesn't like sitting in this.
no, okay. Yeah, absolutely, and
She should sit around the table and to have a,
I mean that's what I would like to see.
and to offer her some food, and then she would take, because she's not supposed to be fed at this age unless she doesn't know, but she has to practice, or she has to
Absolutely. And let's come back to the seating. So you'd put a table there, and clearly that seat is completely inappropriate.
To communicate with her. ארוחה אמורה להיות איזו סיטואציה שיושבים אחד מול השני, ולא אמא עומדת ונלחמת במעליה. כלומר, זה אמור להיות יותר רגוע
But it hurts. I mean, you can see why. I think you can see why she's got in this situation. It's not that she doesn't care; she's desperate. What about not only the chair she's sitting in? What about the environment? Okay, she's eating on her own. Absolutely, it's sloppy food. It's just liquids. It's not. And at 17 months, she should be eating real food.
You can try to explain to her, talk to her. She's old enough to understand certain things. It seems like the mother is completely ignoring
Yeah.
what the child is trying to say. Maybe not verbally, but she's not referring to her. She's trying to give her the food, and that's it. She's not trying to communicate
Yeah.
to her, maybe try to talk to her. Maybe making more playful so the.
Yeah, I mean, those should be interactive. They should be enjoyable. There should be an opportunity for talking. She hasn't said a word. What about the house? What was your appearance? What was your impressions of the house? It was very clean. It was very clean. And would you feed a child on a white carpet? I mean, this is it's all set up. It's just not appropriate for a child. I think the worry was that the child would, if you let the child eat by themselves, that she would make a mess as well. And that meal lasted a long time. It was 35 minutes that meal took. Okay, so what was advice was giving? I mean, you've said it all. You encourage independent eating, giving solid foods to try and relax and not be too stressed. And when all's said and done, we need to go back to the growth chart perhaps, but she wasn't failing to thrive that badly. She was sort of on the second centile. She was actually going okay. One could be fairly comfortable about holding things and saying, just try a different way of doing it without worrying that if she doesn't keep pushing the child to eat, that something awful is going to happen.
What age you recommend to put the child and give him to eat by himself? It's 1 year, and all the meal will be what he eats by himself.
Okay, now that's quite a controversial question. At the age of 7 months, a baby's able to reach out, take some food and eat it. So for sure from that age you want to encourage finger foods. That means they need to be sitting in a situation, which means a high chair, preferably, and could sit on someone's lap, where they can do that independently. There's a branch of dietitians who are very militant about this and say that we should not use any spoon feeding at all. That the control for feeding should be entirely with the baby. And one of the good reasons for doing that is that if you can't force a baby to eat too much. One of the big problems is not so much failure to thrive, it's obesity. And if mothers, and we'll talk about that in a few weeks' time, but if parents are pushing their children to eat, they're much more likely to gain weight excessively. So, and it's very controversial because most dietitians feel that if you allow babies from the age of 7 months to only feed themselves, they can't manage a spoon yet, the sorts of foods they can pick up and eat, and particularly if they're healthy foods, are not going to give them enough calories to grow. I don't know what the solution is. I'm very sympathetic to the idea that the baby should feed themselves and the control should be with the baby. But I don't know whether that answers your question. Okay, how did she do? It was difficult working with her. The mother was very worried that if you let the child feed herself that she would vomit. And it was difficult working around the anxiety that the child would vomit. But she progressed, as you could see, I think. Okay, that's her. Right. This is, now we have Jane, who's 15 months old. Okay, so here she is below the second centile, and then following intervention came up here. So a very slow decline to here. Okay, so Jane is 15 months. Jane's father works long hours in an arms factory. Mum is a housewife. Mum is very quiet and difficult to communicate with. The sister has speech delay. And this child is drinking 3 pints of milk a day. You don't know what pints are, 1.5 litres of milk a day at the age of 15 months. Oh. Sorry, it's okay. Okay, so this is Jane. No, it's not chashuch. I don't. It's not meant to be dark. It's not at my screen. It's not dark. I'm not quite sure what. It does look dark. I don't know why. Makes a difference then. Okay. No? That's right. And usually people say, where's the sound on this? But actually, if you listen very quietly, there was a clock ticking in the background, and there was no sound because not a word was said. I haven't written down how long this meal took, but no, and the sister is being seen by a speech therapist for speech delay. I'm sure, because there's no rich language or not much language at all in the home. So what does one do about this situation? Treat the mother, okay, yes. Okay, no, I mean, that's right. No, it can help. It's very sad that that's the solution. What about on the medical side, the nutritional side? What can we say there? Yeah, cut back the challah. How much milk should a child of 3 have? Yeah, we say 500 mils, but it's certainly not that extra litre. What about the way she's eating? The child was completely passive. She needs to be given some opportunity to eat independently. And this mealtime went on forever. So once again, shorten it. If you haven't got food in the first 5 or 10 minutes, the chances of you getting it in the next is minimal. So, and it's a nightmare. So shorten the meal. I think it was very hard to read her, actually. I'm not sure. So this is what we recommended. I think you've said it all, right? And the outcome was that it was, as you can imagine, it was very, very difficult to engage with her. She may have been depressed, but it was very hard for her to express her emotions about what was going on. And we didn't actually get long-term follow-up because the family moved away. The weight was still borderline when she left. Okay, Katie. Katie's 12 months. Katie's dad is a banker and her mum is a housewife. Her mother's concerned about Katie's dietary intake, and her son also had terrible eating problems as a toddler. And then we got Mum to talk about what it was like when she was a child herself. And she told us that when she was a child, she was made to sit at the table and eat all her food up. This could take more than an hour for her to finish the meal, and sometimes it actually made her vomit. So it just gives you something, a bit of an understanding. Oh, it's gone again. Oh, this is very annoying. I thought I'd loaded them all up. Okay, so I said that's Katie.
Where's the doggy? Where's the doggy? Hooray! Where's the doggy? Where's the doggy? Enjoy it now. See?
Okay, what do we see here? Mum, what was she like? What was happening there?
Desperate.
Yeah, she's one of our desperate mums. So what do we think about that? Yeah, and that last look at the end when she turns around and looks at the nurse is just, that's desperate. What would you do? Turn off the television's a really interesting thing, because why do you think she has the television on? Exactly. I mean, that's usually why it is, but clearly it's gone beyond that, and the child who's got little interest in food just wants to sit. You just want to switch it off. And, you know, Mum just gives up in the end. This child is 12 months. Okay, I've written down she's not weaned at all. She was eating... Well, she was trying, it was just sloppy foods again, but it was sloppy. And this was a mother who didn't allow her to handle food. And when you know about the mother's background, the story that she was made to eat till she vomited, you can sort of be a bit more sympathetic about the fact that she's worried about giving solid foods.
But she's doing the same.
Yeah, she is. Yeah, cycles of things going on. We pass it on to the next generation. What sort of advice would you give her? Ken. Yeah. I mean, to some extent, people often ask me, well, you know, this is an artificial situation. You know, they've been told to film a meal. and therefore it may not be representative of how they normally eat. But on the other hand, it probably is, you know, that if somebody came to say, will you feed your 2-year-old or 18-month-old, you'd probably sit down with them side by side, and I don't know whether you'd eat as well, but it would be a relationship there. So, I mean, in this one, she was advised to give food more frequently, certainly solid food and finger feeding. The child needed more independence and to interact with the child. And this mother wasn't like the last mother. You felt that it would have been so difficult to get her to understand quite how to communicate. It was so foreign to her. This mother had the capability of doing it. She probably just doesn't see mealtimes as being a pleasant place where you can eat together and enjoy food together because of what she had. So this advice was hard for the mother, but actually the outcome was very good. Whoops.
באזורים האלה שם האימהות לא מדברים עם הילדים שלהם? כל הסרטים בינתיים אין מילה.
Absolutely.
לא אומרת מילה.
Yeah, listen, I mean, time and again, it's what we don't know that when we see them. Do you know if your patients talk to their children? And maybe it's something. Food is so interesting. I'm sure that food in England is different from food in Israel, but okay. Okay, let me tell you about Martin. Okay, Martin lives on a rundown council estate where there's a lot of vandalism. Mum is in a volatile relationship and she receives little help with the children. It's such a bad area that the professionals have been told that they mustn't visit there because of their own safety. But Pauline went along anyway, despite the regulations that she shouldn't visit. The meal has lasted 15 minutes so far, and it's going to go on for another 30 minutes. It's been going for 15 and it's going to go on for another 50. This is so annoying that it's not. I spent hours putting it in. Okay, here's Martin anyway.
Mandarin, baby.
לא, זה האמא. Okay. Now what you need to know is that in this meal that lasted 50 minutes, the child got off the chair a lot of times, and each time the mother picked him up and put him back on the chair again. What was he eating? I think there was banana there. It was one of those homes where the nurses say, you know, you go in and you don't want to sit down. And you also don't want to be offered a cup of tea. But anyway, so there you have the scene. You would never pick that up in the clinic. Here's a child who is not growing well. What would you advise? Yep.
More attention from the mother because she doesn't see the chair. She sits very far.
Yeah, I mean, this,
The mother and the plant were doing the same thing.
the mother and the plate were doing the same. Oh, the plant were just sitting. Yes. Okay.
לא, היא לא מעורבת. הילד מנסה לקרוא לה, הוא עושה משחקים כדי לראות איך היא תגיב, הוא שופך ומסתכל.
And nothing. Nothing.
אמא ממש לא קיימת. חשבנו שזה בכלל.
Yeah, I mean.
הילד הגדול הוא בדיוק.
אבל היא אין ככה.
הוא גם שם קופץ, ואמורים לשבת סביב שולחן, כלומר כל האינטראקציה של
Yeah.
הארוחה שהמשפחתית היא לא ארוחה באמת.
I mean, and what's worrying is that you would never know this was going on, but if most mothers thought a nurse was coming in to feed a mealtime, even if a mealtime was like this normally, you would do something, right? You would sit by the child. The lack of awareness of what was appropriate.
It's not exactly true that you wouldn't see it not going home to see I mean, you see this parent with a child
and
in
there's,
the clinic.
And there's no interaction.
They don't care when the baby's crying because the doctor is checking him. Nobody's consoling them.
You're right. You're absolutely right. There will be signs. I suppose it hits you harder here. What happened was that, I mean, the advice that she gave was, once again, it's so common, reduce milk. Stop the bottle, reduce the amount of milk. Having a routine. The important thing was that this mother was actually depressed as well. So it was arranged for her to go and see the family doctor to have that addressed. Length of meal, 50 minutes. That child wasn't going to eat more than another mouthful, however long you stayed on. That was only after 50 minutes, and it went on for another 20 minutes. There's no point in pushing meal times longer than, while the child is interested. And what was good was that social services were involved, and they found somewhere else for the family to live, which was a better housing area where it was possible to have a healthier environment for the whole family to be in. He did well. I won't try and show you all the slides because it takes too long, but his growth was very good because, as you can imagine, this child was actually somebody given adequate food and he was hungry, he would eat himself. But the outcome overall wasn't really brilliant, and at the age of 5 he was referred back to us for severe behaviour problems, which also doesn't surprise you. Okay. Next we have Carl. There's 2 more. I should tell you, hang on, before I do that, let me tell you a bit about them. How do I stop it? Okay. Okay, this is actually not filmed at home, it's filmed in the gun. Carl was born 2 months early, and as you'll see, he's got mild CP. His parents have an unstable relationship, and they've had very little experience with babies or toddlers. Carl has a tendency to vomit, which clearly makes things harder for the mother. And at the age of 1 year, he was still eating very sloppy foods. He's now 20 months. So that's his mother, yeah, it's his mother feeding him. She came to the nursery to feed him. No, it's not the same family. Okay, that was a 45-minute meal. He's actually a child who drinks juice all the time. But what would you do in this situation?
What I didn't understand is he's not able to use his hand because of the CP?
No, it's a hemiplegia. His left hand is clearly he's not functional, but the right hand is perfectly normal.
Why is he helping him with this?
She's bluffing him. He eats by himself, or she takes his hand.
Yeah.
The plate wasn't in front of him.
That's right. Oh, yes, you're right.
The plate in front of him.
אולי כדאי להתחיל בכלל איך הוא יושב, כי שולחן גבוה מדי בשבילו.
אולי.
הראש אצלו בהיפראקסטנציה כמעט, והיד שלו הכינה לו כפית שבכלל לא מותאמת לילד הזה, אז חישוב המזל שלו מותר לילד.
Absolutely. So start with getting, I mean, yeah, he could be, I don't think that's the prime problem, but get the seating better. I don't think that was the worst thing by any means. Yeah. Yeah, no, absolutely. Yeah. Actually, it's worrying it's in gun that that's happening. What else was the mother doing? No, she was testing the heat, I think. She kept blowing on it and testing it. And why, if it was okay at the first mouthful, does she have to keep doing it? So that's one thing she's doing, which is very bizarre. What's another thing she was doing?
When he started crying, she still put it in.
Yes, certainly she was doing that before that. Yeah, but the other thing she was doing, she was teasing him. She was sort of giving him the food and then pulling it away at the beginning. Before he started getting upset, she was going like this, and he looked at the and then she pulled it back. And then, you know, that awful thing, I don't know, you just sort of sit there thinking, is he going to choke on you? You know, and then she pushes the bottle down as well. So, I mean, clearly there's work to do around that somebody needs to sit with her and help her and guide her in how to feed him.
All these examples show that it's not the feeding that's the problem, it's the whole interaction between the mother and the child.
Thank you. Okay, if you walk home with that message, I'm really happy. So what was done? So it was encouraged that he should finger feed at least, even if he's a bit slow in learning to use a spoon, but maybe he can use a spoon. She should stop cleaning him. There's nothing so irritating if you're eating, somebody to keep wiping your mouth. She needed to learn more about what cues he was saying. When he was hungry, he was fine. He was eating really nicely at the beginning. When he'd had enough, respect it. You're going to gain nothing except get him very resistant to eating if you keep pushing a child to eat when they're not ready.
I don't think he had enough. I think he was frustrated.
You think so? Maybe you're right. Okay. I mean, the important thing is read what's going on. Yeah, I suspect you're right. The other thing that happened, which was very nice, was that there was a special nursery for children with CP, and he was referred to the nursery, and the mother made friends there, and you know the whole life changed, and so suddenly she was well supported. He was with children who weren't so dissimilar from him. She was with parents who had a similar child who was mildly disabled, and the outcome was really good. And there's one more if you have the patience. No, it's only one more. Now you have to listen. This is real Yorkshire being spoken, not just English. Oh, I'll tell you the background afterwards.
Apple. Oi! Come on.
That was your dad's coming. Daddy, come down. He won't eat his supper.
Come in. Stop! As soon as I went to the door, I mentioned your name, right? Me and your boy sat down and ate dinner.
It worked. That's what she said.
It worked.
It worked. And everybody laughs at that one, but it actually makes me want to cry. You know, the idea that a child can be brought up like this. But I mean, the background is that he lives in a damp house. The father's unemployed, which is why he's upstairs and can be called down. Mum has bouts of depression, and she is concerned about her bad temper. And she was really angry to be referred. You know, this is common with families in this sort of area, that they're referred to social workers, and they don't see it as being supportive. They're just really angry about it. Nurses in Tipat Chalav are somewhat better off, but nonetheless, the idea of professionals coming in and poking their nose into what's going on in the home is very upsetting for them. Anyway, this was a 45-minute meal again. Nathan drinks juice all the time, which is probably why he's got no appetite to... and when I say juice, it's not good fruit juice, of course. It's sweetened sugary water. So what was done here? I'll shorten the story for you. Pardon? I find a job. You know, yes, social determinants of health. No was the answer. It was beyond her abilities. But she did get them a table and chair. There was no table or chairs in the house, and that she managed to get them. So that was a good... Reducing the... I don't think... It's very common in England, in poor families, that there isn't a table. People all do everything in the living room with the sofa. You know, I don't know where children do homework or anything, but she actually got...
Like the other family, they were sleeping on the couch.
Yes, if you like, yeah. And you know, when you say it's a good idea to have a table, people will now turn around and say that's very politically incorrect to say that, because culturally there are some cultures that don't have tables. But there's a big difference between having a culture where you sit on the floor together and the family sits together and they eat out of a common pot, even with their fingers, than not having the concept of having a communal meal. Okay. He actually did quite well. She was encouraged to give him small amounts of food. New housing was found for him. They didn't find a job for the father, but there was housing for the family. And the mum was referred to the GP because of concerns about her concerns about her temper. And he actually did well. I mean, I have to say that, you know, Pauline was terrific because she managed to overcome the barrier of working with this family and was really helpful. So the reason, in part, why I show these, let me just get back to my original slideshow. What was interesting to me, although you say, well, you sort of know what's going on in a clinic, what happened when we were doing this trial was that children would come in, and my diagnosis was it was nothing to worry about, just a small child, just a bit of weight faltering. But I included them in the trial because we were desperate for the numbers. And I'd said to Pauline, well, you know, this one is randomized to you, but I don't think there's a problem there. And she would go into the home and find this sort of thing happening, where there was real help and support that they could be given. That, as I say, yeah, you're right, I might have been vaguely concerned about something going on, but I didn't have that insight to really know what could be helpful with these families. And so I think there's really no substitute for this, but I appreciate it's a costly thing to have somebody going to the home and working with the family. And I guess the important thing is that if these mealtime observations are being done, it's very important it's done for the purpose of helping the family rather than judging them and you know, putting backs up. And she was very skilled at doing that. So I guess that brings us right to the end of this session. I thought I'd summarize about the guidance that we give, which I know isn't very specific. I mean, Chava was talking about how nice it is in pediatrics if you can have an algorithm, you know, sort of weight loss, poor weight gain is like this, therefore you do this, then that leads to that and so on. It's not like that in weight faltering. I think that, you know, for a minimal amount of difference in the weight, you can have really severe concerns. There can be quite what looks like worrying falls off in weight when actually it's just a healthy, well-developed but small child. So it takes our best of skills as paediatricians, I think, to manage it. And there aren't any simple, straightforward answers for any of it. But to summarise, for the food rules, we would say, is that young children need frequent, small meals. Don't outface them with too much to eat on a plate. You can always give more and at least have the satisfaction that they've finished what they have. You want to go for high-calorie foods and be particularly wary, I think, of parents who are overly healthy when their child is showing poor weight gain. Reducing drinks can help, whether it's milk or certainly juices. Don't let any meal go longer than 20 minutes, and that's probably too long. And make sure that the meal is enjoyable, social. Meal times are the things that have wonderful outputs. It's associated later in life with better language, better academic achievement, less crime, less drugs. Family meal times, if we can install that, there's hope that society will change. Yeah.
לגבי ה-high calories, לי יש קצת בעיה עם זה, גם הדיאטניות ממליצות על לילדים קטנים, תנו שומנים, גם שומנים לא איכותיים.
I'm the same, I really do, I know. I mean, some of our dietitians do that as well, just give them sweets, chocolates, anything to make their weight go up. Yeah. Well, because yeah, the problem is that they're more likely to like sweet stuff. There's no question. We're built. Yeah, but we're born with an innate preference for sweet things. So it's not surprising that children who don't have much appetite like sweet things. But like you, I really worry at the idea that we're causing awful behaviour. And I would rather go for focusing on good quality meal times with healthy but calorie-rich foods, and that should be the message. Good.
ממליצה על חטיפים לילדים, חטיפים, מה הם חטיפים? ילדים, מה, אוכלים הרבה חטיפים. אז מומלץ כאילו שיורידו כמה שאפשר, או להפסיק. מה את חושבת?
For a normal child, absolutely, I would cut them out completely. When you've got a child who's gaining weight so poorly, I can't see that giving that, I don't know whether it's good or bad, but giving that advice to a parent, they're not going to believe you or trust you. I think you almost have to, I would ignore that and say what I want to see is sitting down at a mealtime, even snacks, don't let them wander around with snacks because that can reduce appetite. Better that you have a sit-down snack time, and if they eat those foods when they're sitting down and they're talking to their mother, that's okay by me. But you'll get, I know that a number of dietitians will say just get anything rich and sweet in that you can, and I think you're causing problems. I mentioned earlier, coffee break, that there's research that shows that if babies show rapid weight gain from a low point to a higher point, they're much more likely to be obese as children and then later as adults. And I find that...
Them we don't treat usually. If you have a baby that's born on 25th percentile, just for example, and after a few months is over 97, then you don't usually refer them to anyone. You just say,
well, I think you probably should.
Because the baby
I know.
So well, and
let's discuss that next time we all meet. But it sort of reassured me that I don't know how successful. Yeah, I don't know how successful we are with poor weight gain, but there's some indications that it's very good. We're not so good at it because if we're too good at it, if you push weight gain in infancy, you can cause problems in later life. And there is a handout. I don't know where Karen went to. Yeah, okay, and it's on the website. But in terms of meal times, I'm repeating myself, limited length. You want to make it enjoyable, encourage independent eating, encourage social eating. Let's see. So the other issues is that you definitely need to address the social issues and isolation. Be aware of mother's mental health problems and make sure that they're managed. Nurses can be very helpful, and if you gun, as we discussed, can also be helpful. And so that brings us. Wait a minute, just before we do, can we just whip through this and see whether we have answered things? I leave you to say what is the best advice and what is the worst advice. We've sort of skated around that, but I presume you all want to go home, so we won't focus too much. How to approach deal with parents. I hope that that's given you some hints for how to approach parents and the sympathy that's needed. The red flags, we didn't talk about red flags. I think the big red flags are if there's other things you find, particularly if there's developmental concerns, if there's any suggestion that there's dysmorphism and so on, then it's not so much the failure to thrive, but clearly that's a red flag that this is a child who needs special attention. There are red flags from the social point of view if you're worried about abuse or neglect. But I haven't given you any indicators, and I don't think we've got time to think about when is weight gain poor enough that you really jump up and down and perhaps admit to hospital. When to refer, we talked about who to refer to, and I think that gives some guidance about when to refer, when there's oromotor feeding difficulties. A speech therapist can be helpful. General developmental concerns. But there was a whole section we did do that on. When is picky eating a problem? I think it's where the family sees it's a problem, that knowing that picky eating is a very common problem is helpful, and hopefully kids grow out of it. What the real issue is that it's very closely associated with poor weight gain, and whether the poor weight gain is due to the picky eating or the picky eating is a result of the poor weight gain and the pressures that's put on the child, somehow we need to unpick that and try and get meal times to be more relaxed parents to be more relaxed, and hopefully if one keeps offering the right sorts of foods, most children will, that will resolve, certainly by the time they start Ghana and are eating with other children. Practical what to do in the short term, I think we have addressed that. The follow-up agenda, I think the message is to be supportive to families and see them as often as they seem to feel is needed. How long do we need to follow up in the long term? I think, I would say that, I don't know, what would you say?
It's on the right track.
Yeah, no, that for sure. But if you're not sure they're on the right track, how long? This is the balance about if you keep asking them to come back, are you increasing their anxiety?
I think that the thing is that because we are like a family doctor, eventually they see you a lot.
Okay.
So
Yes, that's your advantage.
Yes,
yeah.
They see you a lot for everything. It's not, we're not specialists. They go to once a month or every 6 months. So you can always ask when the child comes in, how's he doing? You can always weigh in.
Yeah, and that's actually much healthier than if you follow up too closely. It can just increase the anxiety.
You can see with your own eyes, even if you don't ask the question regarding his weight problem or the feeding problem. You can see with your own eyes if something is wrong.
Yeah, and if you're giving the right sort of help, they'll come back if they feel that you can be supportive to them. Work up and when to worry about pathology, very rarely, but and only if there's other indicators in your physical examination or history that suggests there's something going on. What biro, we talked about that. History, physical exam, yes, investigations, very little. The prognosis, that on the whole, these, provided they're not children who are born with other concerns, the prognosis is actually excellent, and that should be the big message we're putting across, and it should be the big message we're giving to nurses in Tipat Chalav. Stop creating anxiety when it's not merited.
That's very important.
I think
then
so.
They come running to us crying.
The definition of failure to thrive, I talked about, when is recommended one should start asking questions. I don't know whether it's exactly when should one be concerned, but the crossing 2 centile lines, being under the 2nd centile, those are things that are worthy of talking to the families and examining the child. And if you're not worried at the end of that, then say you're not worried and be very clear about it. Don't let there be lingering doubts. There's nothing worse in the specialist end that a baby comes with failure to thrive, they get 1 or 2 investigations, they go off, they come back, they see the mitmacher next time who thinks of more investigations, they come back again and somebody thinks, oh, we didn't do that, and they do another one, and all along these months go by and there's a concern that there's a real medical problem going on. I think you need to rule out a medical problem very early on, right in the first few weeks when you see them and there's concern, and once you've decided there isn't a medical problem, then you focus around the things we've been talking about, the eating and meal times. How does the approach vary with age? We've touched that a little bit, but I don't think we can enter it now. I mean, just seeing the different videos of children of different ages, I think we did talk about that. So, I mean, I'm happy to have questions. I'm not in a rush, but I suspect everybody wants to get home in this weather. So, thank you, and